Well, good afternoon. Welcome to this month's Cancer Wellness Center Staff Chat. My name is Priscilla Andrews. I'm the clinical manager at the Cancer Wellness Center. If you're joining us for the first time, welcome. If you've come back for another one, it's good to see you again. The Staff Chat series was designed as a way to provide the Cancer Wellness Center community with insights into common issues and concerns through being able to be a part of a discussion between two professionals. And I am so excited here to have, and I see we lost our video just for a second there. So I'm so excited here. That's okay. I'm so excited to have here with me today, Julie Grandolfo. A little bit different than our past staff chats because Julie is actually with JourneyCare Palliative Care and Hospice. She is an advanced practice nurse there. So she's joining us today to talk about palliative care and hospice. And I was I will admit, Julie, excited to hear that in addition to your experience with JourneyCare, which it sounds like started last fall, prior to that, you have almost 20 years experience as an oncology nurse. So I'm so glad to have all of that wealth of information and knowledge. So Julie, thank you for being here with me today and with us.
Thank you. Thank you.
Yeah. Something that I always like to ask people as we're sitting down here together is just curious if you would be willing to share kind of what drew you to the field. Sounds like you spent a lot of your career in oncology, have now shifted to palliative care and hospice. What drew you here and what kept you here?
I think I kind of stumbled upon it by chance. I started in newborn intensive care the first 6 years of nursing, and then we moved. I was at Lutheran General. I lived close to there. We moved out here to Crystal Lake, an hour away, and the ride was terrible. So I ended up applying for a job at Good Shepherd and thought, well, I'll make my way back down to their special care nursery where my wheelhouse was, or what I thought was, and I never left the Young floor from there on out. It was the perfect fit.
Wow. So
Yeah.
you found your second home, it sounds like.
I did. A lot of good people, a lot of good friends from there, and now good contacts from there.
Yeah.
We network a lot.
And there was a shift for you to palliative care and hospice. Curious about your interests in that specific area of medicine.
It kind of goes parallel with the oncology patients. I mean, a lot of what we see on the floor is non-curative. So, you can use medicine to support for so long, and chemotherapy and radiation, and then you kind of come to this gray area where you could keep on with your treatments, or they're not for cure, they're just to hold things off, and people really need a little extra support for that in between area. And sometimes I get a patient that's very close to hospice, but the word itself, hospice, is very scary to a lot of people. So this is a good support place to be for these people when they're just in between.
Yeah. Well, and I so appreciate you saying that because, I've found over, the last decade that there has been a little bit of an evolution as far as people understanding the difference between palliative care and hospice. And at the same time, I think there is still a lot of taboo around hospice, right? And a lot of confusion about what palliative care is. Like I think a very typical response I'll get if I suggest to a participant, have you looked into palliative care, is they'll say, well, I'm not ready to stop treatment. I'm not dying. Is kind of their automatic response. And I'm curious, what your response would be to somebody being suggested palliative care, but getting a sense that was saying, well, you're end of life.
Yeah, I get that a lot. I still get that a lot, even with current patients. So I try and explain to them that palliative is actually just extra support. So we'll see you more often sometimes than the oncologist. We'll see you more often than your primary care. A lot of times, if you're living with a person with this illness, you may not pick up these little subtle changes, but we'll see it because we're there every 4 weeks with a fresh set of eyes. So,
Mm.
we're kind of a bumper so that we don't have to send you back to the hospital and then decline back again and put you back another week after you've stayed in the hospital for 4 days. And then, I try and explain hospice once we're at that point. And sometimes I even have to say, forget the word. Let me just tell you that this is a different way to treat what you have. And I may even use an analogy, like if you have a common cold and you take cold medicine, you're not treating the cold, you're treating the symptoms. So this is where we're at between palliative and hospice. And if that cold medicine doesn't work anymore, you move to something different. So
Mm.
it's two different treatments, just not for cure anymore at this point, but still treating how you feel.
Gotcha. Because palliative care, just to put a point on it, palliative care, you can still be in chemo, you can still be pursuing radiation and
Mhm.
other measures that
Yep.
are targeting the cancer itself. It's
Mhm.
just you're also getting that supportive care around, you fill in the blank. When you get referred to palliative care, what is that able to address beyond the medical treatments the patient may be receiving?
Side effects to chemo. Say you come home and the medicines they gave you, think it's because they're first line for whatever your side effects are, they're not working. Of course, if you're nauseous, this medicine isn't working, you're not going to eat, you're not going to drink, you're going to end up dehydrated. We're there for the in between to shoot in with any kind of medicine that we may have outside of what the oncologist has already sent you home with. We can consult back and forth with the oncologist. And in my case, my area is around my home. So I know all of these oncologists. So there's a good rapport and I know what their routine is. So I
Mm.
can kind of carry out the same routine outside of the office and outside of the hospital to support them that way.
Well, and I think to me, what I've witnessed for people who have gotten engaged in palliative care is just a huge increase in quality of life. And and I think in addition to the physical benefit, I think the emotional benefit of having that care provider that really is focused on how are you feeling, and not like in a 5 minute way or sort of,
Mm-hmm.
I don't want to characterize oncologists or oncology nurses as not caring about the side effects, but there's only so much time that they have. And
Yeah.
that's very different in my experience that I've witnessed than when somebody is getting that sort of targeted care that's just looking at how are you feeling? Are you able to do the things that you want to do?
Mm-hmm. Mm-hmm. And we have conversations like, someone will say, I have to go every week for these lab draws. I have to go every week to get these infusions. I don't want to go. I'm sick of going. And they just keep giving them to me. So I just sit down and say, if you don't want them, don't get them. And
Mm.
sometimes the light bulb goes on. you know, Medicine's trained to treat what they see. So, of course, if your hemoglobin's off, you're going to get prescribed a unit or two of blood. But if you don't want to do this anymore, we have systems set in place that can help you with how you feel because of having these low lab values instead of sending you back to the hospital. And sometimes that's all they need to hear is
Yeah.
you do what's best for you.
Yeah. I work with our multiple myeloma group, right? Such a chronic cancer. And, I think it's an evolution for many of the people in there to sort of not just follow marching orders. I mean, I think there is, kind of the power differential between a patient and an oncologist. And here the patients are relying on the oncologist. So, takes a particular type of personality to just outright feel comfortable saying, can we do something different? Like, can we space out my treatment more? Can I take a break
Mhm.
because I want to go on vacation?
Yeah.
Between that and just the fear of what will happen if I delay my treatment. So, to have another medical professional saying, you know, your quality of life is important. Like, talk to your doctor about what your options might be.
Mhm. Mhm. Yeah. Yeah. I mean, I'm telling you that sometimes the patients look at you like, can I really ask that? Well, of course you can ask that. You're the one that goes home and doesn't feel good. So let's see what else we can do. Sometimes we need to call the oncologist ourselves and talk it over, but for the most part, I think sometimes people just need to hear that they're in charge and they can say no. It's okay.
And I think the other side, and tell me if this is accurate. I mean, I think the other side of palliative care's benefit, one side is saying, hey, do we step back from treatment or do we change the frequency? How do we make this more manageable? But I think the other side is when you have the support to manage the side effects or the symptoms of the disease, then are you more capable of being compliant with the treatment regimen that the doctor's recommending for you?
Hmm. Absolutely. Absolutely. Yeah, it makes it a lot easier. A lot easier. Say if you could, you know, take yourself off treatment for a month. If you're, it's relatively, it's not slow growing, it's not fast growing. Just 4 weeks off of treatment can really do something for their spirit. It could do something for them physically. And then they go back in and they're like they're awake. My mother-in-law gets chemo. She has colon cancer.
Mm.
We just took her to the last appointment and she said, I am just so tired. I'm tired of coming here. I'm tired of wearing this pump for 3 days. So we looked at the oncologist and said, what can we do? Is this safe to
Yeah.
stop this for a little bit? And he said, absolutely. Let's take a month off and then we'll restart again. And it was like a anvil just lifted off of her.
Yeah.
So it helps. It helps. You're anxious the entire time because you don't know what's going to happen.
It's some of it, I think it sounds like is even just helping to prompt patients to open up conversation and communication with their doctor that they may otherwise be reluctant to have.
Mm-hmm. Mm-hmm. Yeah. Yeah. It just kind of opens up a line of communication for them. And sometimes it takes it for us to call and say to the doctor, like, did you know this was going on? Did they tell you? Sometimes they won't tell them.
Yeah.
What else can we do? Here's what I'm thinking. What else can you tweak the regimen a little bit? So, it's a nice palliative's a nice little extra eye in the sky so that we
Yeah.
can keep tabs and we're in their home. So they're more comfortable in their own atmosphere telling you about some of these things they may be embarrassed about.
Yeah. Oh, and it's a different perspective, right? I mean, what I hear you saying is I'm looking at it through a particular lens, which maybe your oncology team's lens has a small overlap with it, but like that's what I'm honing in on when I'm looking at you.
Mm-hmm. Mm-hmm.
Yeah.
Definitely. Definitely.
So if it's okay, I kind of want to switch, from the palliative care, which again is I'm in treatment, I'm dealing with chronic illness, maybe I'm dealing with progressed illness. I want some management of side effects. I want to improve my quality of life. Yeah. Now, hospice, different than palliative care. So, how would you distinguish the two lines of care?
Um, well, eligibility in itself for hospice, it starts out with a less than 6 month diagnosis, like a less than 6 months of life left. And sometimes you can gauge that. You can't really, pinpoint it ever. But, you come to this point in treatment and you have to say, look, here's where we're at. where you need more help. You need somebody here to see you more often than once a month. With hospice, there's a nurse comes out twice a week, and then they get CNA help. And at this point is where they probably are having trouble getting in and out of the bed, getting in and out of the bathroom. So all of the durable medical equipment comes with hospice also. So you get equipment support, you get medicine support, you get social work. There's a chaplain that will come to your home, because at this point, it's a good time to start getting your entire family ready for this big change that's going to happen in the next few months. And, I do get the comment, well, I'm that's just giving up. You're just putting me to sleep. Nobody puts you to sleep. It's not like on TV. And so many times I've had to explain it. You manage the medicine here. Your family is taught how to give you this medicine. You tell them how you feel. They treat what they see. They're on call 24 hours a day for hospice also. So if it's 3 a.m. and the family they don't know what else to do, the help is a phone call away for them. So I try and spin it as support and freeing up the whole family to be family and not caregivers and tasks.
Yeah. Well, and I think, something that you said there just made me think of, and this is going off on a tangent a little bit, so forgive me, Julie. I think to me, one of the challenges with hospice is so frequently people don't enroll in hospice until like the last 3 days of their life. So I think hospice kind of gets in some ways it's good, right? In the last few days of somebody's life, there is that support there. But I think in some ways hospice gets a bad rap that, I think going back to that idea of like, I'm giving up, that like, well, the moment I enroll in hospice, that means I'm going to die in a couple days, which in reality, my understanding, correct me if I'm wrong, is that people who enroll in hospice sooner tend to have a bit prolonged life in relative to being at the last phase of life, but really benefit from being in hospice at that point.
Because the people you see that wait till the last few days have been miserable for months, and it could have been better managed. There could have been more equipment or more conversations about these goals of care. I mean, if you don't want to transition over, tell me what you want. Where do you want to go with this? Because we're very limited at this point. So we have to work with what we have. And I mean, it's not giving up. It's just a different way to treat what you have. And being miserable is a choice. And I still leave it out there. I said, doing nothing is a choice. Doing something is a choice. But make an educated decision and look further than right now. Do you want to feel like this until the last minute? Or let me at least try and help you until the last minute. If you don't like what I'm doing, I step back. But I guarantee you it's going to be better than waiting until the last minute.
The thing that I often talk to people about when either they're approaching end of life or they have a loved one who's end of life is, you're really shifting what your hope is about. And there's a grief process there, right? Because when we talk about being hopeful in the cancer world, that what we leave off is the next part of hope, which is I hope for cure, or I hope for stable disease, or I hope for no evidence of disease, right? And so it's a different mind frame to say, okay, that's not what I'm hoping for. What I am hoping for is quality of life. What I'm hoping for is to have the conversations I want to have. What I'm hoping for is to see my family, right? So, I think to shift that perspective that like entering hospice is not giving up hope. It's just changing what it is you're focusing on working towards.
Yeah, I mean, we're all once you're you have a terminal diagnosis like that, I try and tell people the train is still running in the same direction, no matter what we do. But what we do on the ride is what makes the difference. The end point's the same. And no one wants to hear that. Nobody wants to hear that there's an end point or this is terminal or they're going to die. But, it's what you do with the time in between so that there's not so much turmoil and angst and sadness and all these things. You want to add quality to those miles before the end of the line.
Yeah. Well, and I'm curious if I'm guessing you've encountered this, whether it be through JourneyCare or your work with Good Shepherd, which is, and I just had this experience yesterday where somebody said to me, I see that my parent is declining and we were ready. We thought we were going to enroll them in hospice. And they said, no, 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 no. And I see that they're suffering and I see every day they're declining rapidly, but the person that is declining doesn't want to talk about it, doesn't want to hear about it. I'm curious what insight or guidance you may provide to that, whether it be the adult child or the spouse that's kind of coping with that situation.
Yeah, sometimes you get through to them, sometimes you don't get through to them. But when it happens to me, I just use the angle. I use the angle that it's a different treatment. So, if one thing's not working, let me help you. I'll ask, like, where are you right now? Tell me what you see is happening to you right now, and tell me what you don't like about it. Let me tell you how I could make that better. So if you break it down into smaller portions, like I have this terrible back pain because I have this thing pressing on my spine. Okay, here's the kind of things we could help you with if once you transition over to this service. Maybe a different bed would help you. We could pop your knees up, take the pressure off your back. We could get you special pillows. We could, if you break it down all into the parts that bother them the most of what's happening, then sometimes it just kind of opens up this window of opportunity to be like, okay, you know what, maybe I'll think about this.
Yeah.
You know?
It's sort of, it sounds like really trying to get people to see what the function of this thing that we call hospice care is, and not get caught up in the word hospice, which, like I said earlier, I think a lot of, if not taboo, there's a lot of connotation. Right.
Yeah.
It's a short word, but there's an iceberg underneath the surface when you say
Yeah,
that word.
there definitely is, because they all equate it with dying. And I mean, most people are afraid of the concept. So nobody wants to see the end, but do you necessarily want to be on such a bumpy road all the way there?
We got to get the shocks in the Cadillac fixed so we can have a smooth ride.
That's right.
I think another scenario, I will admit, I think a lot of the time the people that I end up having conversations with hospice about, and I don't know if this is because by the time their people are too sick, I'm not seeing them, is I talk to a lot of spouses or adult children who are watching this decline in their loved one. And I think the other scenario I see is, they're still on treatment, and yet I see that there's a decline going on, but we're not ready to end treatment yet. But I can see that hospice might be on the horizon. What is your recommendation as far as, when people initially reach out, and even what happens when people initially would reach out?
Well, I mean, we break down all the parts of the treatment when somebody like this comes to you and say, here's what we have to work with. going forward, this isn't going to necessarily make your life any longer. You'll just have a bigger job to do in between this time, between now and the end of your life. It'll just be a bigger job, and we want to make it more condensed and smoother on that road to the end. I mean, a lot of these patients come to me from the hospital or from the nursing homes, we'll call. There's a big handful of them that come directly from the doctor's office. They'll refer, but a lot of times these people have already almost exhausted these treatments and want to keep going. So sometimes you just kind of have to put up a sign that says, here, these are all the things you're telling me you're feeling. Do you still want to feel all of these things? Sometimes people want treatment until the last minute. So all you can do is try. We have a really, really good liaison over at Good Shepherd from JourneyCare. Kathy Hendricks is over there, and she is a longtime Good Shepherd person. So she's got plenty of experience in oncology. She's got experience with the doctors there, and she really sits down and has these baseline conversations with people. It's not like when the oncologist comes in and spews off all the big words, and she just all the way down to earth lays it out. All of it's always an option. And I mean, we really have some good people out there at these sites to kind of ease that transition. And then we have an APN call them once they get home or back to their facility. We have an APN call them and discuss eligibility and say, tell me what you see today. Tell me what you want to see in the next few months. And then we kind of break it down into what we can do, what we can't do, and we take it from there.
Are there times when, I mean, I hear you talking about the scenario where a healthcare provider refers. Can a patient or a patient's family reach out for like a consultation or to find out what their options are?
Absolutely. Yeah, they can absolutely call the office number. Normally, in order to go into the home, we need an order from the primary care physician or oncologist or cardiologist, who's ever writing that order. We can also go into the home, not necessarily with an order for palliative or for hospice, and just sit down and have this goals of care discussion. Because some people think they're much worse off than they are. And you get there and say, oh, well, all you really need right now is home health. Sometimes you find out it's not as bad, but we can go into we can go into facilities or homes and just sit and have a goals of care discussion. Where do you want to go? How long do you see yourself doing whatever you're doing right now? What kind of things do you think you need help with right now? And then we go from there.
Because it sounds like in that scenario, you could have a patient that is maybe declining, maybe treatment's not as effective, or they're running out of maybe the next treatment option, but they want to keep working at it in that way. Then they might get referred to palliative care instead of hospice.
Mm-hmm.
Is that accurate? That it's, if you see you're declining, you're dealing with, multiple side effects, or, you've done one treatment and that stopped working, and then you go to the next treatment and maybe that stopped working, but you're not ready yet, you could still contact the palliative care hospice people.
Mm-hmm.
I mean, I always say to people, if you're thinking about it, why don't you just reach out, so that at least you have that information when you're not in an acute crisis.
Mm-hmm.
Because what I see is people wait, and then they're in an acute crisis, and then they've got all these new people that they're talking to and all these new people coming into their home, which is super overwhelming.
Yeah. It's better to be prepared And we have had a few times, I've had a few patients that have called in themselves just by word of mouth. They've heard at church, or they've heard from a friend that they use JourneyCare and they had this wonderful experience. And then they call, and what they think they're calling for is hospice. And then they end up with us on the palliative end. And we explain that in the beginning when, at our first visits, we go over goals of care. We go over, signs, symptoms, things that we treat. But then I also add in, if and when you're ready for hospice care, let me tell you what's available while we're still here and with it and in spirit enough to make a solid, educated decision. Here's all the things that are available. When you feel like you need these things, you tell me, and I will help you bump right over to that in a seamless transition. And I will assemble all of the people and the parts that you need. And then they can at least do this planning in their head and know that it's not going to be running the last minute and scrambling for somebody.
And, I think that those are such hard discussions for families to initiate within themselves, like to even know what to say or what to ask. And I do find that, depending on which oncologist somebody's working with, there is a wide range of comfort level in having those discussions about the prospect of end of life. So just the value of, hey, it's okay for us to talk about it. It's okay for you to be thinking about it. It's normal for you to be thinking about it. It's beneficial for you to be reflecting on what your wishes are, so that there's some choice involved. I think, as you said, when the time comes when maybe you can't articulate as well what you may wish for.
Yeah. Yeah. And, the family is really, it's usually the wife that I'm talking to for this kind of conversation where she says, I don't know when, I don't know what I need. I don't know what he needs. And I'm right here to be the in-between person. I have more conversations with the spouse normally than I have with the patients in these kind of situations where I'm like, listen, tell me what you see, and I'll tell you where we're going with this. If you feel like you can't handle this, or you need more hands on deck, or you need, I have one patient who's had a stroke, paralyzed on one side, and his wife does all of his cares and turns him and gets him up into his wheelchair, and she has one leg.
What?
So, yes, I swear I saw with my own eyes.
Give this woman a medal. Jeez Louise.
I'm telling you, a gold medal for sure. And, I said, look, where are we going with this? We've done the physical therapy. It's not working. We've done the swallow studies. It's not working. Now his blood pressure's out of control. I can't anticoagulate this fella because he's got something else wrong with him. He's immobile. He's had a stroke, and he is still smoking to this day. You need more help here. You need more help. I think we're at this turning point. So, it took about 3 visits. And then finally she said, you're right. We can't go on like this anymore. I'm exhausted. He's exhausted. And,
shifting that, for taking a step back to reassess, and even for families to take a step back and reassess.
Yeah.
I cannot believe it. We're in our last couple of minutes here. It gets to the end and I'm like, at the beginning, I'm like, we have so much time. And then at the end, I'm like, where did it all go? like sand through the hourglass. I think one thing that I just would like to clarify, even for myself, honestly, is what is included in hospice and what is not included in hospice?
Well, I can tell you in a nutshell that palliative care is an APN once a month. We don't have any other ancillary departments that work with us. With hospice, you don't necessarily get an APN, but there's a doctor that overlooks all of the hospice patients. The nurse comes twice a week instead of once a month. You get the added CNA 3 times a week. to help with, wound changes and baths and things like that. There's a social worker, there's chaplains available, and then the service is on call 24 hours a day with hospice because, things don't only happen during business hours. So, they can call. There is always a nurse that answers that phone at JourneyCare. So even if it's something small, they can call and say, hey, I was trying to empty this Foley catheter, and a nurse can answer that. They always have a nurse answering the phone. So it's really, hospice is a lot of support, so it can free you up for just to be a family member.
And I just saw a question, somebody asked what an APN is. That's an advanced practice nurse.
Yeah.
We're not professionals
I know.
if we don't have acronyms. I mean, we got to have acronyms. How do we distinguish ourselves from the general population, right?
Yeah.
I think one of the things, I think the one thing that I didn't even realize for a while is the thing that is not included is home health care. If you're wanting somebody there 4 hours a day, 8 hours a day to be there, or needing respite care so you can leave the house, that's a fee for service that maybe hospice JourneyCare can help get referred to, but is distinct from the services included by hospice.
Yes, a little different. I'm not sure if they still have it, but I know they did have a respite program where you could have your loved one in the inpatient unit for a day or two so that you could get things together at home. I'm not sure if they still have that or not on that end, but they used to. They used to. But yeah, there's not anyone that could stay an extended period of time, but they do a lot of education with the families so that they feel comfortable being by themselves for an extended period of time and administering meds or what have you.
Julie, and I hear somebody from JourneyCare says respite is available for 5 days at a nursing home under the hospice benefit.
Okay.
Because hospice is covered by insurance and covered by Medicare. So it is something that would be covered versus being an out-of-pocket expense.
Yeah, hospice, as long as you have Medicare, it covers all of it, including the medications. And all of the medications and equipment is delivered to the home. So it also frees up the family because they're not running all over the place to go pick everything up. Even wound care supplies, everything's delivered.
Just streamlines everything. Julie, I already said that. I feel like I could have so many questions. You said something in there and I was like, Priscilla, don't ask the question because we're at our time already. I want to thank you so much for joining me here today. Want to give you a moment to just put a plug in for JourneyCare right here as we're ending. If there's anything you'd like to say about your organization.
I mean, call us anytime. We're always available to discuss, what's eligible, what's not eligible. And, these are nurse practitioners making these phone calls and answering these questions. So if we can't provide it, we usually know where you can get it. So we're a good resource, whether we can provide the service or we can give you a couple of ideas of where to go next for treatment. Because between the 7 of us on Palliative, there is an extensive background between cardiac, oncology, geriatrics. So one of us will know the answer if you need something.
And I see here, if you want to call JourneyCare and get more information from them, maybe you want to say, Julie, can you be my advanced practice nurse?
Anytime.
Where you can reach JourneyCare at 844-6-JOURNEY. That's 844-6-JOURNEY. And is it just journeycare.org? Is that the website, journeycare.org? Julie, appreciate you sharing your expertise and your insights here. Thank you for taking the time this afternoon.
Anytime. Call anytime.
And thank you, everybody joining us here on Zoom or on Facebook, or perhaps if you're watching this on YouTube. I will be back here in July, so be on the lookout for our calendar and our upcoming program flyer for more information. Thank you all. Happy 4th of July weekend coming up, and be well. Take care,
All
Julie.
right. Thank you.